So we're dispatched to a 70-year-old male with a chief complaint of chest pain, and he is unable to stand due to a syncope and dizziness. He has a past medical history of an MI 5 years ago, but his wife who witnessed this event said that it wasn't the same as prior. Patient presentation: he is pale, clammy, eyes open to voice, but he is unable to obey commands. From this, he is a GCS of 10, made up of 3, 2, and 5. The patient's medications are silazepam and aspirin. From his OBS, we have a heart rate of 170, a BP of 70/40, a BGL of 6.7, a rest rate of 18, and a temperature of 37. From this alone, I'm going to call for backup. AUT1 to comms.
Comms receiving.
Calling for an R50 for a status 1 patient, over.
Copy, 20 minutes.
Cool, thank you. So his level of compromise is very severe at the moment. I think he's in conscious VT, but first off, we're just going to rule out some differential diagnosis. First off, SVT with aberrancy, we're going to rule out just because he, of his age, he is more compromised than SVT would commonly be with aberrancy. He has a longer QRS in his 12-lead ECG, and he has a right axis deviation. We're also going to rule out sepsis because he has no temperature. He's also been well previously, so there is no signs of infection. Electrolyte abnormalities we can rule out because, one, he isn't on dialysis and he doesn't have a history of these abnormalities, and the patient history doesn't indicate any anaphylaxis or hypovolemia causes. So from this, I'm going to give a working diagnosis of conscious VT. So we are going to have to cardiovert today. First off, we're going to lay the patient in a supine position. We're going to grab our IV roll and gain large ball IV access. Next, we're going to go through our cardioversion checklist, which is in our pocket CPGs. So we're going to place the pads on the apex, sternum, or anterior-posterior positions, in addition to our 12-lead ECG electrodes. Next, we are going to ensure that the defibrillator is in manual mode, which it is. We are going to select a lead with a visible R wave, which we have, and ensure that the artifact is minimized. So there's no artifact here. We can also print ECG lead if we want to, an ECG rail if you want to see this. So yes, that is fine. Next we're going to press synchronize mode, so there's the sync button, and then we are going to confirm that there is a detection symbol above every QRS complex, which there is here. We're going to select joules, which would be the max of 360 joules. We're going to charge our defibrillator. While charging, we're just going to ask everyone to not touch the patient when we shock the patient. So everyone stand clear, shocking the patient. So shocked the patient, and then we were going to recheck the rhythm. So we're going to determine the rhythm, which now he is in sinus rhythm again, and we will check for a pulse to check the compromise, the cardiovascular compromise present. If we had to perform another cardioversion, we would administer a second cardioversion and make sure that the defib is synced to the rhythm. If our patient was able to obey commands, we would give ketamine as a sedation if indicated, and we would call clinical desk for that. We've been dispatched to a 40-year-old male who has fallen off a 6-metre high roof and landed on his occiput. With rapid assessment, we have found an isolated injury on his occiput with a boggy spot 6 centimetres in diameter. The patient was found supine with posturing and extending. He was restless, combative and grunting, but settled after morphine administration. There were no other findings, no blood loss, and we found his GCS was 5, made out of E2, V2, M1. His vitals we found were a heart rate of 50, a BP of 160/90, a rest rate of 12 that was irregular, and a temp of 37 and a VGL of 7.6. So we immobilized his head by using 2 towels next to his head and 1 underneath to have the optimal airway positioning. He is maintaining his own airway now, and we've got a non-rebreather on him at 10 litres per minute. We have the defib connected with the defib tabs and the 12-lead ECG also connected, and we've got a ETCO2 ready and going. We've got a BP cuff attached. We have got a BVM mask with PEEP at 5 centimetres of H2O. Ready also and waiting. We've got a suction that has been tested and turned on, and we have gained bilateral IV access with running fluids on standby. We have also got an SpO2, and we've got morphine drawn up if patient becomes combative once again. So just looking at the presentation of the patient, we are querying a severe TBI due to mechanical fault, but we're going to rule out other causes first too. So we're going to rule out metabolic causes. Hypoglycemia is ruled out due to his VGL being 7.6. Hypo and hypothermia is ruled out because he has a regular temp of 37. Cardiac conditions can be ruled out too because the monitor is showing sinus bradycardia at the moment. So we are thinking a severe TBI for this patient, so we're going to call back up for RSI, ICP. So AUT1 to comms.
Receiving.
We're requesting an R50 for severe TBI. R50 with RSI, please. Over.
Confirming ICP is 10 minutes away. Please prepare for RSI.
Okay, so preparing for RSI, we're going to use the checklist. So we are going to first attach a nasal prong without oxygen. We've got that ready here, standby. We are going to prepare oxygenation using a reservoir mask at 10 litres per minute, which we have, and a BVM mask of 10 to 15 litres per minute with PEEP at 5, which we have on standby here. We're going to attach ECG, a BP cuff and an SpO2. We're going to position the monitor so that it can be seen. We're leaving right-sided space on the patient's head for intubation equipment. We've gained bilateral IVs, prepare a running line of sodium chloride, which we have, position the patient for optimal airway control, which we also have with the towels. We've got an ETCO2 ready. We've got the ETT holder with the strap undone underneath the patient's head. We've got suction that ensure that it's working, which it is. Turn it off again, and we're preparing. We've got a BVM with PEEP ready. We're going to now obtain another set of vitals, and then we're going to update the ICP if possible with the condition of the patient and the new set of vitals. We're not in an ambulance, so we're going to prepare the area for RSI. So we're going to clear the area so that there is access on both sides of the patient and that there is a right side available for the intubation equipment next to the head. So the RSI will be attempted twice. If it is unsuccessful, we will use an LMA, OPA or MPA to ventilate with a BVM after that. During the RSI, the ICP may require a BERT procedure, where it's backwards, upwards, rightwards pressure on the trachea, which we can assist with. Also, we can assist using a bougie. This is used to find anatomical landmarks, so we can help by feeding the tube over the bougie. If RSI fails and successful ventilations cannot be obtained, a cricothyroidotomy will be performed by making incisions of the skin over the cricoid membrane.